is Richard Taunt, and I'll be chairing today. I'm very pleased to have a range of excellent speakers here with me in Skipton House. We'll go round to do introductions in just a second, but we're still a bit before 12, so we'll allow colleagues a few more minutes to arrive, and then we will start properly. But just to say thank you very much indeed for joining, and we'll be starting in just a couple of moments. If you'd like to ask any questions at this stage, please use the questions function on the webinar and send it through, and we'll get back to you as soon as you can. So we'll go on to mute for another minute or so, and then we'll be kicking off at 12 o'clock. So thanks again, everyone, and we'll be with you in just 1 second. Good morning. Well, it's actually now. Good afternoon, everyone, and thank you very much indeed for joining this webinar on PHC's Prevention Concordat programme for public mental health. My name is Richard Taunt, and I'll be chairing this webinar. Just so we've got a range of colleagues already on the line, and thank you very much for joining in already. We're also expecting a few more to join. So I think what we'll do is we will kick off with some introductions at this and then we'll get into the topic proper. We're not going to go around to do introductions across all colleagues just because we are quite a large group, and so if we were to do that, our hour may suddenly disappear, and we'd rather that didn't happen. So we'll start with just some introductions at this end.
Hi everybody, my name is Maeve Hartwell, and I'm one of the public mental health managers here at Public Health England. And I'm working with two other colleagues in the room here who will introduce themselves on the Prevention Concordat programme. And we're just absolutely delighted that so many of you have taken the time to join us today. So thank you very much for that.
Hi everyone, my name's Phil Moore. I'm a GP and I chair the Mental Health Commissioners Network of NHS Clinical Commissioners. And I do a lot of work around mental health commissioning. And I think commissioning has got to include prevention, so I'm delighted to be part of this.
My name is Lily McCura. I'm Deputy National Lead for Public Mental Health and Wellbeing here at Public Health England. And I've got particular interest as well as sort of leadership role on prevention and promotion.
Hi, I'm Adam Aiken. I'm working with Public Health England and supporting Lily and Maeve in this important work.
So thank you very much to everyone here. Thank you again if you've just joined. Thank you for joining us today. Can I say that we've had a number of requests from colleagues who couldn't make this time for us to be able to record the session and make it available afterwards, which is what we're going to do. So just so colleagues are aware that we're recording this session. Just to set out how colleagues can get involved today, there are 3 ways to contribute, and we are hoping for a really constructive 57 minutes that's on the clock. So firstly, to join in the discussion verbally. And to do so, all you need to do is to click the raise hand icon, which to me always looks a bit like sort of an upside down hairdryer. But if you see it as a hand, that's great. But if you just click on that, that will flag up with us, and then we can unmute you, and you'll be able to join in the conversation. So that's number one. Second is to use the questions function to join in by text. And please do put in questions or comments or requests for clarification. Please do that through the text function. Equally, if you can't find that raise hand icon and want just to put in a comment, please can you unmute me so I can join? You're very welcome to do that too. And then the third option is actually, this extends both for this webinar and beyond, is if you want to email us any comments, please do so to Tanuj, the email address there. It's also Tanuj who you should give a ring to or drop an email to if you're experiencing any technical difficulties, and Tan will do his very best to assist you with that. So we're really, really grateful that you've joined us today. We really welcome your contribution both on this webinar, but still very much that we hope that you'll continue to be involved in the programme and send us content once this webinar is finished. I should probably just finish the introductions by saying properly who I am. So my name is Richard Taunt. I work for a social enterprise called Kaleidoscope, and we are working with Public Health England in implementing this programme. So I will say, if you do have any questions at any point, please do use, particularly the text function would be great. We're going to come on to discussion at that point. Please do raise your hand and join in verbally. But we're going to start with Maeve and setting up the background to the project.
Thank you, Richard. So we're going to use the slides that have been circulated already. So hopefully you've got those in front of you. And I'm just going to take you through those to set the scene for this work. So our aim in the Prevention Concordat programme for better mental health is to galvanise action, local and national action, around the prevention of mental illness and the promotion of good mental health. And we want to do this by facilitating every local area to put in place effective prevention planning arrangements. And we see these being led by health and wellbeing boards, clinical commissioning groups and local authorities. And our aim is to provide the best support we can by the end of 2017. But it will be a programme across 5 years leading up to 2020. And we want to enable every area to use the best data available to plan and to commission the right mix of provision to meet local needs. And I should say at the beginning that when we're talking about prevention, we really mean it in the widest sense, from the promotion of good mental health through to living well with mental health problems and everything in between. I'm sure many of you will be familiar with the basis for this work, but this work came from a recommendation in the 5-year forward view for mental health, which the 5-year forward view plus Future in Mind really highlighted the cross-society consensus for a need for change and for the need to really move upstream, that the boost in early intervention must be accompanied by a similar focus on mental health promotion, prevention and improvement. And at the bottom of this slide we've got the specific wording from the task force and the actual recommendation itself. Our approach is deliberately broad, so we're trying to fulfil and develop this programme around our Public Health England's approach to public mental health, which is informed by WHO's approach to public mental health. And our goal is that everyone, irrespective of where they live, has the opportunity to achieve good mental health and well-being, especially communities facing the greatest barriers and those people who have overcome the most disadvantages. And this includes people living with and recovering from mental illness. So how are we going about trying to support this programme of work in its first year? So the first thing we're trying to do is create a suite of resources to support local areas to develop effective prevention planning arrangements. The first of these was a rapid review of evidence, which was commissioned by Public Health England and developed by the Mental Health Foundation and published in July this year. And it was exactly what it says, a rapid review of the evidence of what works and a summary of interventions across the life course. And that's informing the programme as we go forward. The second tool being developed is the Mental Health Joint Strategic Needs Assessment Toolkit, which is primarily around ensuring that local areas have the data they need to understand mental health in their locality. So that's a combination of an online data tool using Public Health England's fingertips profile and a user guide helping people to understand how to use this profile and to signpost to ongoing guidance once you've understood your population needs. And that's being developed by our colleagues at Public Health England in the Mental Health Intelligence Network. And that's due for publication towards the end of January. The third resource that's being developed is the Mental Health Promotion and Prevention Return on Investment tool. This is being developed by LSE. They produced the first publication of this in 2011 for the Department of Health, and Public Health England has commissioned an update taking account of the 5-year further years of evidence, and alongside a kind of updated publication, there's also going to be an Excel-based tool which will enable local areas to input your local demographic information and understand of the selected, it's about 10 interventions, of the selected interventions, if you were to invest £1 for a group of your population, what kind of a return on investment would you see in your local area? So the idea is to have that level of local flexibility, which is new. The first time it was just an online, it was just a paper publication, and this time it's a paper publication accompanied by a user tool. And then the fourth resource that we're developing before the end of March 2017 is local prevention planning guidance, and that's really the focus of our conversation today and the work that we're doing together. We want this to be a guide for local areas to help them develop the most effective prevention planning arrangements that they can, and we hope that it will tie together the 3 previous resources that I've outlined, and this is what we're going to hopefully discuss with you today to get your input into what needs to really be in that guide to make it as useful as it can be for you in your roles and for colleagues in other parts of the local health economy. And the 5th element in our first year is training for elected members, so local authority elected members who are mental health champions, to support them as prevention-focused leaders. So there's going to be 2 pilot, sort of effectively masterclasses for them at the end of February, and then that program will be rolled out in the forthcoming year. So in terms of the first year of the program, we see our role as providing information and resources to the system, and in years 2 and 3 we hope to help the rollout of those resources, and that shaping of that work is still kind of under development. So how we are going about developing this planning guidance is informed by stakeholder engagement. So this is our 5th webinar that we're holding today. So we've had 4 previous with different groups, and we're also holding 4 face-to-face events up and down the country, as well as being very kindly invited to speak at, I'm going to get the name of the meeting next week wrong.
It's the Mental Health Commissioners Network annual conference, and one of the breakout sessions will be around this very topic.
So we're going to have another opportunity to speak to clinical commissioners there as well. So just to say about those events, there are still spaces remaining. We're going to have the first event next week in Birmingham, followed by York next week. The following week is Bristol, and the week after that is London. And we would be delighted if you or colleagues that you know would be interested in joining us. Please do make them aware of the details of the event. So alongside the stakeholder engagement piece to understand the needs of the users of this guidance, we've also commissioned the King's Fund, and they're undertaking a stock take of good practice from across England at the moment. And that's a mix of a random sample and a selected sample of local areas, a total of about 30 local areas, and they're primarily doing desk-based research to understand what is written for a specific area, what is written about mental health prevention, the prevention of mental illness and the promotion of good mental health in the local health and wellbeing strategy, in the overarching strategy for the clinical commissioning group, the housing planning documents, a selection of appropriate documents. And this is being also complemented by some qualitative interviews to get a sense of, we know that this work is not starting from zero. There's a lot of work going on across the country that's really leading the way in terms of the best and most effective prevention planning arrangements. So the work that the King's Fund is doing is trying to synthesize where are local areas at now, so that we can hone the guidance to take account of this and to make sure that the guidance is adding to what is already happening in the field. So I think probably that's a kind of canter through the programme, where we're at and where we're going towards. So I'm going to pause there.
Maeve, thank you very much. And I see questions are starting to come through in the text. That's great. What we'll do is we'll take a few of those and then respond when we get to discussion, if that's okay. So you're absolutely not being ignored. We're going to come to that in the discussion. Maeve, thank you very much indeed. It would be great to get back to some of those points. I'm going to pass to Phil.
Hi everyone. I think most of you will be aware of NHS Clinical Commissioners and its Mental Health Commissioners Network. We are very aware that as mental health commissioners we can often plough a pretty lonely furrow and have to be making the case for investment in mental health. Despite all the hoo-ha at a national level, we're often having to make some pretty difficult cases in financially stringent circumstances in our individual areas. And we're not always backed up by a huge number of other people. So part of the network is to give a strong collective voice for us so that we can push back against national things and make sure that mental health is kept on the agenda, and we're able to share best practice with one another, ideas and development opportunities, so that you feel that you are supported within a network and not simply as much on your own as you might otherwise be. And that's really what lies behind the network as a whole. In terms of mental health promotion and prevention through particularly early intervention, you may have seen recently our paper that we published, Support from the Start, which gave some good examples of early intervention going on around the country, particularly at a primary care level. And hopefully that's a useful document, but I'm drawing your attention to it as an addition to what we're discussing today. I don't want to say a great deal because I'd rather we had discussion, but I just want to remind us that there is a definition of primary, secondary, tertiary, and you may or may not have heard of quaternary prevention. And I just set out a slide to say, what does that mean in terms of the work that we're doing? So the quaternary prevention is making sure people aren't over-medicalized and we keep them actually in the community as functioning citizens. And I think our interventions around physical health in people with serious and enduring mental health conditions is part of that. Then there's crisis care to make sure that people are dealt with when they do get into difficulties in mental health, and they're helped through the recovery pathway back into the community and back into being as productive as they possibly can. Secondary prevention is around crisis avoidance in those with a mental health condition. Let's make sure that we get in there early and prevent them progressing to anything that is more radical. But the bottom one is really what we need to be doing, and that is promoting mental health and preventing the onset of mental illness by intervening upstream at every level. And it starts at the perinatal period. We need to get into primary schools, into junior schools, and into secondary schools. We need to get into youth clubs. We need to get into the society in general so that people are given the ability and the permission to articulate what it is that's going on in them. I had a young friend who was at sixth form, and she came to talk to me and she said, self-harm is almost epidemic in the school I'm going to. It was a very well-to-do school. She said, a lot of the girls don't know who to talk to, they don't know who to turn to, and probably have some difficulty in expressing the things that are going on. And I think that those are the kind of things that we can begin to get into and begin to help young people have a vocabulary and a structure to begin to talk about those things and discuss them, so that it is permissioning for them to share those things so they don't end up on their own and therefore going down a particular route. Huge area, but that's part of the whole prevention program from start to finish of life. So what does it mean when we talk about delivering prevention? One of the things we end up talking about an awful lot in our Health and Wellbeing Board is how do we recreate and re-establish community, and how do we support people within our areas to do exactly that. Because part of mental health resilience is, what is your relationship area? What is your support network? And how can we foster peer support to ensure that people are integrating within their communities and aren't simply on their own? We all know that when you get a mental health issue, you want to withdraw, you want to isolate yourself. And how do we encourage people to create those networks before they get into difficulties, so that then they're not on their own and can't so easily withdraw when they get into difficulties? We want to reduce the reliance on acute services, because we shift the focus to prevention. And we all know that people get into crisis because there aren't the services that are there, easily accessible and very responsive at the time they need them, and we need to change that around. And finally, we need to achieve better outcomes for crisis prevention. I don't want any more to hear about people phoning a crisis line and them saying, fine, go to A&E. That is not intervention in people with a crisis. We've got to get very, very much better. I have seen good models in visiting the USA where peers are beginning to run the crisis intervention lines, because they're the ones who really know about it, and they're supported by professionals, but they're also trained. In New York City, for example, they're training peers for action within their groups, and they're aiming to graduate from next year 200 a year trained peer support workers. We need to have a vision for doing a lot more. We have got challenged resources, and if we aren't creative about the way that we engage those with lived experience, I think we will miss a huge opportunity. So prevention is actually a very broad remit. It needs to cover from sperm to worm, cradle to the grave. It needs to cover all eventualities through our lives. And if we don't have that vision, I think we will miss something in terms of the 5-year forward view.
Phil, Meg, thank you very much indeed for kicking us off both so well. I just wanted to remind colleagues just about how you're able to contribute today. 3 particular ways. Join in the discussion verbally. Just raise your hand, and we'll bring you in. You can use the question function to send in comments by text. There should be a little question mark icon to help you do that. But equally, if those options aren't working for you, or you'd like to contribute after the webinar, please do email us, email to news, and we'll feed those comments through. Just before we get on to the discussion proper, just one question of clarification. Maybe great if you could answer this one from Sarah Lee. Thank you, Sarah, who asked, how are the King's Fund identifying good practice? Are they surveying local authorities and CCGs?
Thank you, Sarah, for your question. So they are at the moment in the process of developing their criteria to find good practice, and once they've assessed, so that the initial desk-based research is to understand what is out there, and then to use that to form criteria to understand what does good practice look like. And once that good practice criteria has been defined, they're going to be selecting a number of case studies to be written up, and that will be included in the guidance. They are not at this point undertaking a full survey of local authorities and CCGs, and that was really due to the time that we commissioned, the time in which we're trying to produce this work, and that wasn't going to be a realistic thing to be done within a 3-month period.
A further point, then we'll just get on to the discussion. Thanks very much for that, Maeve. Donna, really nice point for you, thank you, saying there's lots of guidance for local authorities about suicide prevention, which requires, say, multi-agency support.
Yes.
Can we make sure that the guidance supports this work so we don't end up duplicating?
Absolutely. Was it Donna? We are very alive to this, and we see we are absolutely not going to be duplicating the existing guidance on suicide prevention, some of which has been developed by our colleagues here in Public Health England. And what we're going to be doing is considering that the Prevention Concordat programme is the overarching framework, and suicide prevention absolutely has to be part of having effective prevention planning arrangements. and we will be signposting and signalling to the existing work in this area. And we're also, through these stakeholder engagement events, trying to work through, in terms of the model of how prevention planning needs to happen, should that be making use of the existing suicide prevention multi-agency partnerships or not? So we're very alive to the need to join these two agendas up.
Donna, thanks for that input. So I think without further ado, people please do continue to use the text to send comments to, and we'll pick those up as we go through. Just to introduce the topics for discussion today. Meg, we've got two topics.
Yes. Would you like me to take, shall I just do the introductory piece at the moment?
Let's do the introductory piece, then we'll go into the right approach.
Okay. So we wanted to focus today's discussion on two areas. The first being, what is the right approach for the guidance? We want the guidance to be as helpful as possible for local authorities, clinical commissioning groups, and other local services in planning for good public mental health. And we'd really like your advice and thoughts on what is the best approach for the guidance to do this. And we have some further prompters that we're going to come on for discussion in a second. And the second thing we really wanted to talk to you about today was making the case. As Phil has outlined, we are launching this work into a very challenging environment. Local services need to live within constrained budgets and deliver a wide range of priorities. And it means it's vital that we're able to equip local leaders with the ability to make a strong case for public mental health. How do we best do this? And again, we have some prompters for discussion here, and we're very alive to the challenging circumstances. So we'd really welcome your views and contributions on that.
I think it's worth commenting that the challenge is even greater because it isn't just restricted budgets, but the people who we normally look to do some of the prevention work, public health, are having their budgets decimated even more than CCGs. So we recognise that there's a double whammy here, and we need as much support as we can to make the cases locally.
Mm-hmm.
Thanks so much, Phil. Thanks, Maeve. So, Maeve, do you want to just introduce the first set of options, just around the right approach to the guidance?
Sure.
We'll have a discussion on this before moving on to making the case.
So we've deliberately created some caricatures to spark the debate, to help us understand from your point of view what is the most helpful way for us to pitch the guidance. So I'll just run you through the kind of four options that we've developed. Option A, each local area should prioritise 3 to 5 specific interventions. In the guidance, we'll specify which they should be. Option B, each local area should prioritise 3 to 5 specific population groups, which would be specified in the guidance. Option C, every local area should prioritise 3 to 5 specific interventions or population groups, which they should determine themselves, and the guidance instead would focus on advice on the process in order to prioritise these areas. And option D, each local area should have a comprehensive strategy for public mental health, with the guidance not advising on specific interventions, but instead on how to design a broad-based strategy.
Maeve, thank you very much. So this is the quiz show element of the webinar, where we've deliberately set up these options as caricatures. But just to go back to a point Phil made earlier, we really want this guidance to be as helpful as perfectly possible to local areas, local commissioners. And so these are very broad approaches, which would really welcome colleagues' feedback on if when this guidance hits your desk, which of these approaches would you most like to see reflected, or which would you least like to see? That'd be really helpful for us. So just to open it up to discussion, if you'd like to raise your hand, if you'd like to join verbally, or if you'd like to put in sort of text questions, that would be great as well. So so thank you to Tim Rice for putting in a comment saying this needs to cascade into wider partnerships and health and wellbeing boards are variable in terms of membership. Simple things like exec summaries, document dissemination. Also, are the EA involved in this work, as it's so powerful in terms of local authorities? So a couple of things, maybe firstly in terms of the format of the guidance, are we thinking about different options there, and also in terms of LGA involvement?
Thank you, Tim. Absolutely. So the feedback that we've had so far across the webinars has been that the suggestion is that we've at least produced 2 forms of the guidance. One high-level summary, and to complement that with a second, more technical document. so that the high-level summary would speak to elected members, to senior leaders, and would be a synthesis, a summary, succinct and in plain speaking English, and then the accompanied more technical document would get into greater detail. On the question about the LGA are very much part of this process. They are on our steering group and very much involved in making sure that this will speak to the right audience.
Thanks, Mary. I should say the LGA have also been incredibly helpful in promoting the regional events which are coming up, as we'll be working with their Health and Wellbeing Board network in particular. Just to say again, if you want to raise your hand to come in verbally or to come and keep on comments.
And please, just in terms of raising your hand, it might be helpful to just remind people how to do that if they've just joined.
If you've just joined, let me say that you should have a little button which looks like a hand, or if you've got a mind similar to mine, it might look like an upside down hairdryer. But if you click that button, then it will enable us to see that you're wanting to come in, and we'll unmute you. If you're having trouble finding that button, just use the text to say "bring me in," and we'll bring you in that way as well. But just whilst people are thinking about that, a few more comments coming in. Thank you very much, Donna Husband. Again, thank you. Having guidance that says we can interpret the guidance based on local need JSNA would be most helpful. Simon Bryan, you've gone for quiz show option D. Thank you. As each local area is so different, for example, county versus city versus London Borough, this will also need to be relevant for lower tier authorities. Claire Wilcock, thank you very much for joining, saying I'd go for a mix of C and D. Phil, when we were discussing earlier, your option was D with a bit of C, I think. Do you want to talk through your D?
My experience is commissioners don't like being strictured because they feel that national guidance doesn't understand their local demographics. And I do think it's important that as commissioners we have the ability to respond to our local population and design things that are very much specific to them, using the JSNA as a tool to get there and putting the JSNA through the health and well-being strategic process. So I think that's, for me, the starting place, D. However, I think it's not unhelpful sometimes to, at a national level, to have some suggestions or recommendations about specific national priorities around interventions or priority groups that we could consider as a help to dealing with producing an option D for our localities. And my version would be D with a little bit of C in it to give us a bit of a push. But I'm sure everybody else will have their own ideas.
I would very much welcome colleagues to come in. And Phil, can I put you on the spot and say, is there a particular piece of guidance of the past which you've seen, which you thought that really helped me to do my role? And I'll put this question out to everyone joining on the call as well. Is there a particular document which you can think of which came from a national body to support commissioning or planning or approaches?
I think the Crisis Care Concordat was quite a useful one because it said to each area, can you make your plan to deal with the issues that we've identified? And we all had to make a plan to go with that. Now, I'm sure that was a right pain in the neck in a lot of areas that had to be produced, and there was a deadline, and there was a map that was rag-rated and so on. However, I think that process did focus everybody's minds. And if you now look at the map, everybody's green, and they're now reassessing the implementation of that action plan. It wasn't too stricture. It gave a framework, but everybody then was able to respond to their local needs. Just an example of how I think it can work well.
Phil, thanks very much, and very much welcome colleagues' views on the same question, whether they agree in terms of the Crisis Care Concordat being a particularly helpful example, or other examples coming to mind. I would also say to colleagues, we've had a couple of people coming through saying C/D. If you just want to use the question function just to put in one letter, which option would you go for? It'd be great to get a range of views from across colleagues as to which option you'd go for. So do just put in A, B, C, D, and we'll go through, and I'll let you know how people are responding. So David Smart, thank you for bringing a comment talking about the Foresight Report back from 2008, but it does seem to have been forgotten, which addressed lots of needs of children in the workplace, worth revisiting. Of course, that Claire Alcock, and we should declare that Claire, as well as working for CCG, is helping us with this work from Kaleidoscope. Thank you for joining, Claire. Saying she agrees with you, Phil. Congratulations. There's a good thing you've got found.
No, there's a first.
Very helpful to have national suggestions about the freedom to do what works locally. Guidance helpful within local commission organisations to help make it a priority. So, Meg, I wonder if you want to touch on the Foresight report, but just to give scores on the doors, we've had votes for D, D, C, C, D with C, broadly C and D. So if you're thinking A or B, we'd love to hear from you and get your rationale. The Foresight report, is that one we've considered?
It's definitely, I would say, continues to feed into the agenda, and that all the sort of subsequent strategies coming since then have built upon the Foresight report. So, I mean, it's great that it's been reminded for us to go back to it again, but I do think that's fed into the development of things like interventions, which have been captured by Mental Health Foundation's report in the summer. So I agree the report no longer has the profile it did in 2008, but I do think a huge number of the findings are included as the agenda has moved forward.
Maybe that's a really good point about the Mental Health Foundation document from July,
Yes.
July, which if colleagues haven't seen is, I think it's a great document and very comprehensive in terms of its take across the whole agenda. Tim, really nice point. Thank you. Saying broadly C and D, local focus, but regarding D, not a large document on how to develop another document.
Absolutely.
Yes.
It gets slightly postmodern at this point. It may become process rather than actions, but obviously some basic pointers on how to complete a strategy. That point about length is something that's come across.
I think I am. You'd expect me to say this. I'm a GP. I can't read beyond the second page. But it is important that we don't have yet more lengthy documents. And I think that is one where the crisis Concordat was quite good, in that it was simply an action plan that people together. It wasn't exactly short, but it wasn't a huge document of 120 pages that people were putting together. So maybe to take some leaves out of that particular book may be helpful.
Excellent. You're gaining more fans here, Phil. Sarah, thank you. Agreeing with Phil, saying essential for local interpretation on national. David Smartlily asking, what was the name of the Mental Health Foundation document? It was called?
The Mental Health and Prevention, Taking Local Action for Better Mental Health.
What we could actually do as well is make it like easy for everyone is we work out ways of sending you all the links from your PDF as well.
Oh, yeah. Excellent, good. Christina, thank you very much for going against the consensus and saying actually you'd go for A, but interventions chosen on basis of local JSNA. Important to get return on investment and choose interventions which have been shown to be cost effective. Return on investment maybe is something which we've discussed quite a lot, and there is other work going on about it. Do you want to talk a bit about that? We referenced it briefly earlier.
We did. I might actually say that as we come on to the discussion about making the case, Richard, if that's all right. Because I think it fits sort of within that. I mean, just in terms of the right approach for the guidance, another question that's sort of primary in our mind is that we're trying to design this guidance to speak to a number of local audiences. So there's something about how do we pitch it so that health and wellbeing boards, local authorities, clinical commissioning groups all feel that it is guidance that speaks to them, and how do we make sure that, you know, at a local level people feel that somebody is responsible and accountable for making this happen, whilst being mindful of the wide geographical variation. So any thoughts on how we do that? Because from just sort of putting all our cards on the deck, from a Public Health England perspective, we tend to mainly talk to our public health colleagues, and that's primarily done now through local authorities. So trying to speak and cross boundaries with this guidance is something we were sort of, you know, very alive to the best way to do that.
Right, thank you. We've had a comment in via email. Thank you very much. Martin White in Totnes saying, I think there is some merit in option A, in that it's likely to be concise, focused, and lead to action, and allows for action on population groups, as well as wider factors such as media coverage. So again, a clear point there about being concise and focused as a key requirement. And it, well, look, Christina, I think you started a option A bandwagon now. That Chris Naylor, thank you very much for comment. Thank you for your work at the King's Fund supporting this programme. Saying, would it be helpful to have a bit of A in the mix, in the sense of highlighting a few interventions that have a particularly strong evidence base, but stopping short of mandating specific things? What do others think? What do you think, Phil?
I think that is what C is saying, is letting us actually make the final decision, but making clear where there are some really high priority things, either because of priority of need, or because of priority of evidence, or because of priority of cost effectiveness, or preferably all three. And I think that that is a very useful addition to it, without that necessarily being mandated for absolutely every area.
So illustrative interventions rather than...
A bit more than illustrative, giving mental health commissioners some grist to make the argument for it, so that they can push that case locally.
Okay, great. If we can get the word grist into the guidance document as well, I think we should be doing well. I think we might well move on to the discussion about making the case in just a second. And so it'd be lovely just to turn to Megan Phil in a sec, just to get a bit of an overview of this section of the discussion. But just say we've had another comment coming in from Rachel Johnson in Berkshire. Thank you for joining, Rachel, saying, I vote for C. Please can you clarify who should lead on this work and how should it be monitored? Great question. We don't have a mental health partnership board. As we're already working on developing a mental well-being strategy jointly with a range of partners, we haven't got time to wait for guidance how to do this work. So a good point there, Meg, about who do you see as leading this work and how it should be monitored?
Well, I think that's part of where my question was coming from, in terms of who does it need to be pitched at, so that we feel that locally somebody is accountable for doing it. I mean, what we've heard kind of generally in the feedback so far is that we should focus it on health and well-being boards, as structurally they should be the local health system leaders and the decision makers for the area. But we've also heard they may not have the pots of money. So so that's, I suppose, what we're asking the question to everybody in this engagement process. On the other points about monitoring, absolutely, and I think that's something we're at the moment exploring, because we're very clear that Public Health England can't mandate every area to do this. That's not our role in the system. Our role is to support the system and provide resources and tools to help and enhance effective prevention planning arrangements. That said, it is our role also to make information available. So in the second year of the programme, we are going to be developing a sort of monitoring and evaluation process. What that looks like is still going to be formed through the development of the stakeholder engagement. So, you know, will there be specific indicators? And that is still being discussed, and we absolutely appreciate that areas can't wait for guidance to get on with their planning, and we absolutely do not want to hold areas back. Please move ahead, and if there are insights you've gleaned and you'd like to share them with us going through that process, we'd really like to hear them.
Meg, thank you. I think a key point from what you're saying is that a lot of these questions are up for grabs through this engagement process.
Yes.
Thank you. Phil, I'll come to you in 1 second just to go through a few more comments. Then I'll go to Phil, then we'll move on just because of time. So Sarah Lees, thank you very much. Lovely comment. Local strategies giving support through health and wellbeing boards and CCG boards will contribute to buy-in. We have found a common understanding and definition of wellbeing has been really helpful for us. So it'd be great to know what area you're from if you're able to put in that at some point. That's great. Tim Rice saying, suggest that reference other partners such as criminal justice, crime, police crime commissioners, prisons. So again, cross-government departmental support. Police will find this challenging, although some good work done with crisis Concordat. I think we'll absolutely agree with you there. And finally, David Smart, thank you for joining, saying prevention for Concordat as part of crisis Concordat, as this group already established. This enables local groups delivery who report to Health and Wellbeing Board providers attend the crisis Concordat. Phil, reflections, no comments, and this little section of the discussion.
I think there's really good comments coming through, and I absolutely agree that we need to engage that wider group of people, because mental health is something that is of vital importance in all those areas. I just want to make a suggestion that what we have to think about with this is there is not the capacity in all of our local areas to create yet another series of meetings to work this through. And my suggestion is that we all have a think about where can this slot in to our existing processes for developing a strategy to run with it. We're all up to our necks in STPs and love them or loathe them. They're the only show in town. So should it actually fit in with the STP process or some other process that already exists? Because none of us have got the capacity to bring in yet more things. So I think that's a little challenge for all of us in our local areas to say, where will this slot into existing processes so we don't all fall over?
And Phil, that is a beautiful segue into our next section of debate about making the case. Before I go on, I'll just say one more comment in from Martin White in Totnes. Thank you again, Martin, saying the document could be written for each audience stakeholder in an appropriate style, then brought together in one document which is tailored for everyone. Partners can read it to dip into each other's point of view rather than trying to make one size fits all. How we best tailor this to audience, I think, being a common message, Maeve, which we have heard. I think given time, we will move on to the next section of our debate. Thank you all, colleagues, for that. I think that was a really good little mini discussion. Thank you. Maeve, the next section.
Thank you. So we're now going to be talking about how do we make the case. Very exactly as Phil had said, organisations are incredibly busy and incredibly stretched financially, both in terms of resource and capacity. So how can we support local areas to make the best case possible for spending some time and some resource on public mental health? In addition to the moral case for doing this, which of the following do we think the guidance should particularly stress? And we've got another ABCD quiz show moment. A, that public mental health will help local authorities and CCGs meet their statutory responsibilities. And just to say, this came because a lot of people were saying organisations are so stretched, the only thing they can do is currently try to meet their statutory responsibilities. B, that public mental health will help local areas with their sustainability and transformation plans. C, that the evidence base for public mental health is strong enough to release savings in the short to medium term. And D, that public mental health will enable areas to better meet other national priorities such as access to services, development of new care models, or employment.
Maeve, thank you. And it's before everyone says all of them, which is the common response. What we're particularly asking here is which particularly should we try and focus on? Phil, we didn't rehearse this one, so I'll come to your view in just 1 second. But just to say, views already coming in again. Please just put the letters in and any quick explanation. Tim by saying A. David Smart saying A and B by describing C in clear business case plans. Christina saying A. Christina, you like going for A. At the moment, it's very difficult to get elected members to agree to action or release funds for anything that isn't mandated or statutory. Phil?
I am really torn on this one, but let me just talk it through. I think A is a statutory function of public health anyway. So they should be doing that in any case, and it doesn't need this particular thing to make them do it. So let me put that one to one side. STPs, we've got to deliver those anyway. It'd be nice to know that this helps us. D, yeah, really good thing, but I think that the thing that might swing it is that if we can release some savings in the short to medium term, it may catch the interest of our directors of commissioning more than the other ones might, but that's just being very, very pragmatic and mercenary.
Well, thank you, and it's interesting. We're getting a range of perspectives coming in. Linda in terms saying B. Comment here from Donna. We've talked a bit about language, May, so I wonder if you want to pick up just about how we've been thinking about language. Saying when we use the term public mental health, people assume that this falls into public health teams, but it is system-wide, so having this clearly stated would help. We had a bit of discussion, maybe at the last webinar, about the terminology we're using around the programme and how we're using prevention and Concordat in particular. Your reflections on where we are with the language on this programme.
Sure. I mean, Donna, absolutely, we hear what you're saying. We've had this debate in another webinar where there was a fear that if the term public mental health is defined too clearly or too narrowly, then it excludes, because it relies on such a wide, it basically touches upon all areas of local authority business, that having a definition can end up, exactly as you say, people seeing it as not their responsibility, versus if you leave it diffuse, it can get lost and it can get missed. And this is something that, for example, the King's Fund have picked up in a couple of areas, that the high-level public health strategy will reference public mental health and say it's join up and vital role with housing, but then once it gets to you look into the actual specific housing strategy, it's then not referenced again. On the specific words of prevention and Concordat, with Concordat there's sort of particular challenges in that word doesn't really speak to the general public. It's a confusing word, and it also immediately brings to mind the crisis care Concordat, and then there's the complexity of that. And prevention itself, in some ways, can be a bit of a stigmatizing word, because people do have mental health problems, and there's a sense of we've failed, or people have failed if all mental health problems can't be prevented. So we're alive to these sensitivities as well. And so through our face-to-face stakeholder engagement events, we want to explore some alternative language. We're using this to kind of label the program at the moment. It's a kind of internal working title. And people know where it's come from the recommendation, but we are very spending time thinking about the language we use to communicate it externally.
Thanks very much. And I'm just going to, there's a few comments coming through which I'm going to read out, but I wonder if colleagues, if we could actually just flip it slightly and say, of those 4 options, have colleagues got examples of successfully using those strategies in their local area? I'd be really interested in that, and if so, how could this forthcoming work from Public Health England further help you to make the case if you're already built on a platform of success? So just a range of comments coming through. So Donna, thank you very much. Saying C, but savings will be system-wide in both local authorities and NHS. So again, this is tricky when public health intervention saves money for NHS, hence it needs to be a joint approach. And Phil, I'm sure you agree, underpinned by really strong relationships as well across different areas. Sarah saying, in reality, the focus across areas is likely to be C because of the financial challenge. Tim saying, think A and D, not B, as perhaps not wide enough in terms of partnerships at present. C likely to be a challenging debate, and can it be delivered that quickly? Possibly being the key question here will be variable. Diane Bell, thank you for joining, saying C, as this is what people are increasingly looking for, so important in capturing attention. So of course, all others are relevant, but have to be careful about over-promising on ROI. Cost effectiveness is important too. Phil, I wonder if I could turn to you and say, we talk a lot about ROI in healthcare and investors save, and possibly we over-talk about it, so people sort of lose faith that it will actually happen. What's your view on how we use ROI to best make the case with regards to public mental health?
Oh dear. I think return on investment, I've seen some pretty spurious arguments about what you save if you spend £1 on this, and they kind of draw money in from all sorts of non-existent places. However, what we have to accept is that our system is so financially stretched at the moment that there is not spare resource that we can invest in new things. And if we're going to invest in new things, we have to be able to evidence that it's going to have a return on that investment in order to get it past all the various decision-making bodies that it has to go through locally and even higher than that at STP level. So I would love to be able to do what is good and what is right, but sometimes in doing that we have to be able to produce the financial argument as well. In the long term, there is absolutely no doubt that the cheapest form of service provision is the best quality service provision, because the best quality will prevent people going around the system more than once, and they'll get it right first time and so on. But that is difficult to realize in our local systems. We've all tried to do this. So I think whether we like it or not, there is an element of ORI that's going to have to come into all of our arguments, even though perhaps we prioritise the arguments from some of the other areas about what is right to do for our local communities. We can't get away from it, I fear, in the current environment.
Mate.
Thank you, Phil. And I just wanted to add in, because I didn't talk about it before, about the ROI work that's been commissioned. We're very excited about this work, but there are sort of limitations to it because it's limited by the existing economic evidence base. So the only interventions that are included are those with a mature enough evidence base to have return on investment evidence. So that limits the interventions. But the work has been designed to try to listen to some of the feedback about previous ROI by trying to confirm and make clear what are the cashable savings and kind of actual money that will be returned to the system. And at the same time, we are very aware of the kind of local politics of money from one part of the public sector being used as investment and the savings being accrued in another part. We're hoping that the work will expose which parts get the savings, and we're hoping that that could foster the opportunity for kind of collaboration locally. If it's more transparent that by a local authority investing in this scheme, a CCG might make this kind of saving, and that there might be more opportunity then to kind of share the costs. But we are waiting to see the final product on this. So that's kind of where we're up to at the moment. I don't know, and Lily wants to comment on that.
As in on that. So yeah, as Meg was saying, is that so the tool will allow you to be clear about not only who, based on whoever's provided that pound, where does the return come to? So actually, whereas on previous things it said it's giving you the amount for the NHS, and then for the rest of the public sector it's just said other public sector. Whereas this breaks it down to either local authority, fire service, police service, and other areas, and education. So why that's interesting, again, is this thing about the fostering local collaboration, because again, I think, over, but it's not just the last couple of years, lots of years people have tried to think about local brokering on the back of cashable savings, but haven't been able to do it because of this lack of specificity. So one example being that actually might be to your advantage as being in the health system is, some of the interventions that are part of the education system that we know actually will release money to, say, like for example, anti-bullying work will actually reduce the amount of psychosis in the population from 15. So actually that does have a benefit to you. So there's some interesting conversations therefore to be had locally using that.
Lily, thank you very much. We're hurtling towards 1 o'clock. Time is always too short when you're having a good, fun, constructive discussion. One last comment just on the, two last comments which I'll read out, and then I wonder if I could just pass to Phil, then Maeve, just for responses and just a very quick summary across the hour, and then we will close. So very quickly, just say Martin White views that option C will help address the priorities that most parts are facing. Sarah saying, as well as ROI, I think there needs to be recognition that good mental health and well-being underpins our individual ability to take action, for example, to improve our health, lifestyle, and manage our existing health. So it's essential to much of what we need to do to build a sustainable system moving forward for health and care. Sarah, beautifully put, thank you very much. And Christina finally saying, does the panel think there might be a case for advocating for a better care fund type approach or accountable care partnership approach to pooling budgets and integration in mental health? I'll pass to Phil for views across those three and closing thoughts.
Two quick comments. Number one, the thing we haven't mentioned is self-care, and good mental health is a real key to self-care, and I think Sarah has referred to this in her comment, and I think we've got to make emphasis on that, because if we keep people in reasonably good state mentally, or help them to keep themselves in good state mentally, they're more able to care for all aspects of their health. The last bit about where are we going in terms of the models for this, a better care fund, well, that was hard work. Should we be pooling budgets? Absolutely. And one of the things I'm after is to see the amount spent on mental health per weighted capitation in each area. But spent on mental health is CCG, Public Health, Local Authority, NHS England, Public Health England, prescribing, primary care, and probably some other bits and pieces as well. And until we put all of those together, we don't genuinely and properly know what is being invested in mental health care and in mental health promotion in any area. And I think by taking it per weighted population, it becomes a more comparable figure than simply on the basis of population or percentage of other funding. And I'm pushing for that certainly as part of the IAF, and I would like to see that happening in due course.
Phil, thank you very much. Maeve, with the clock ticking, closing thoughts.
Well, I'd just like to really say, first of all, a big thank you for all your contributions. Really valuable. A lot of food for thought for us. I think it's interesting that the economic argument has come out so strongly in terms of making the case. We've also, just to reflect our earlier conversation this morning, we had a similar focus on the need to prioritise the economics to make the case locally, but from a different point of view, which was that if people are well, they continue to be in work, and in work they continue to contribute to the local economy and help to fund all of the services that are now under such pressure. So there's also that economic argument to be made. And on some of the precise questions, so I think that also speaks to the self-care agenda as well. Thank you so much. You've given us so much to think about. And the one thing I did want to mention, was that as well as the stakeholder engagement events, we are going to be doing a further webinar in January to play back to those who've been involved in the process, what we've heard, what we've synthesised, and where we think the guidance is going to go based on all of these comments. So you will all be welcome to join that. Again, it will be advertised in the same way. So we'd be delighted if you could join us for that.
Maeve, Phil, thank you very much both, and thank you everyone for joining. I think it's been a fantastic discussion. Just to say, if you leave the call and suddenly think, oh, I meant to say that, please do email us. Tanuja's email is just there. Please send it through. As Maeve said, we've still got places available for the regional events that are kicking off next week. So if you haven't booked your place, you've still got time. The link is just there. And finally, if I could just give people one piece of homework, if you've got a spare couple of minutes just to be thinking this afternoon, is if you were to be giving us one single piece of advice as we go through this work, one single piece of advice, what would it be? And if you could have a bit of a mull on that and just send us an email back to Tanuj there, Tanuj's email address, that would be really helpful. We are out of time, so we will close it there and just say thank you very much once again, and we hope that you keep engaged with this work as it goes forward. Thank you very much, everyone.
Thank you.
Thanks.